All right, well, hello everyone and good afternoon. Welcome to the first day of CVI. It's been an exciting time. Lots of great cases, and we have a wonderful session here sponsored by SIS Medical on the OPN balloon. You heard already earlier today on the coronary session, Dr. Katri had an introduction on the balloon and how to use it, but here we'll go much more in depth about the specifics of troubleshooting and the practical things you need to know in your practice. Dr. Arnold Sito is co-chairing this with me. We have a phenomenal panel, Dr. Alison Hall, Dr. Max Crucaro, Dr. Nachiket Patel, and I'll have Dr. Sandy Jolly, who is joining us in a few minutes, some flight delays over there. And we'll kick it off. We'll have Dr. Nachiket Patel talk about PCI, open, and expand.
Thank you, Dr. Balakis. Thanks to SIS Medical for inviting me, and thank you all for coming. I'm Nachiket Patel. I'm from Phoenix. These are my disclosures. Just real briefly, I don't want to spend too much time on this, but as you all know, moderate to severe calcification is seen in about a third of patients presenting with acute coronary syndrome, even more so in patients with three-vessel disease or prior bypass surgery. And the presence of moderate to severe coronary calcification both increases the risk of the procedure, impedes stent deliverability, and prevents adequate stent expansion. Not surprisingly, therefore, it also results in worsening outcomes. There's 4 mechanisms for in-stent restenosis, specifically neointramural hyperplasia, stent undersizing, calcific neoatherosclerosis, as well as stent underexpansion. The latter two is where I feel the OPN balloon really shines. So the OPN balloon is a twin-layer, highly non-compliant balloon, and it allows application of pressures of greater than 30 atmospheres. It's been shown to be effective in both native vessels as well as in-stent restenosis. So I have a couple of cases that I want to show you. Just get right into it. First patient is a 76-year-old female who presented to an outside hospital with a type 1 MI, and she underwent a PCI of a severely calcific and diffusely diseased left anterior descending artery, and notably no intravascular imaging was either available or used in this case. So I was able to get the images from the first from that index procedure, and that kind of helps explain how we got into that situation. So as you can see here in the caudal and cranial projections, there's a lot of calcium and disease in the proximal to mid left anterior descending artery. What was done was the lesion was pre-dilated with a 2.25 millimeter balloon, followed by deployment of a 2.25 by 38 millimeter stent. As you can see here, but was not recognized, is that the proximal portion of the stent did not completely expand. So another stent was deployed.
Wait a minute here. So Max, I mean, you have tremendous experience, right? Would you have suspected this from the diagnostic angiogram, and what would you do at this point?
Angiographically, less, but with intravascular ultrasound, sure, you can suspect angiographically there is an eccentric nodule to the edge of the proximal, to the proximal edge of the stent. Maybe I suspect that. That's my personal suspicion. So I perform before we implant the stent. I also such similar intravascular imaging is necessary in such cases. Yeah.
Sure, Alison, what would you do at this point? So you put a stent in, there's a dent.
No, we want to understand which is the distribution of the calcification in this case.
So I think if I had just deployed a fresh stent like this and noticed that there was underexpansion of a portion of the stent, obviously the imaging hopefully will have, if you were able to complete it, will have helped you understand what's going on, but I would probably approach it with either, I would actually likely use an OPN balloon, potentially something like shockwave, or even just scoring balloon, depending on exactly what I'm seeing on the intracoronary imaging.
And Arnold, you're a world expert on physiology. Would physiology have told you this?
Unfortunately, no. It might not be adequately. It might not be a significant lesion. It's just causing stent underexpansion. You might still have a lesion underneath there that's preventing your stent expansion, but still is not necessarily significant. But that's still enough to potentially cause your in-stent restenosis and thrombosis later.
Perfect. So again, we suspected intravascular imaging is key, but excited to see what happened here.
No, thanks. All great comments. So again, that proximal portion, it's kind of hard to tell, but it wasn't adequately expanded, and unfortunately that wasn't recognized. So then another stent was deployed, a 2.5 by 30 millimeter stent, overlapping with that first stent. And I suspect that it was deployed in a caudal position because, and then in the proximal LAD, another 2.75 by 12 millimeter drug-eluting stent was deployed. And the reason I say I suspect that it was deployed in the caudal position is that operator then thought that underexpanded area was just him or her missing the lesion and not overlapping. And so therefore, another third layer of stent, a 2.5 by 12 millimeter stent, was deployed in that mid-LAD. And this...
So we'll be putting 2 5 stents in the middle AD in a man?
I was going to say, no, that doesn't exist. So it's very likely undersized.
It's already a great case because you put in 3 layers into a calcified underexpanded lesion. So this will be a good test case.
Yeah. No, absolutely. So she was discharged the next day. 3 months later, she was referred to me for evaluation as she was, not surprisingly, having ongoing angina and dyspnea.
So it's an option for the audience. We'll just let the patient DAPT and let him go home. Who would do that? All right, so everyone agrees we have to do something, right? And you'll be surprised how many people are told, oh, it's okay, just take the APT and go home. And obviously that's not okay, right?
No, absolutely right. So I went with the 7 French sheath through the groin. What I planned to do was use the OPN balloon to try to expand those lesions. What I was surprised about is that I knew I would have trouble crossing that mid lesion, but what I was surprised that I actually couldn't get anything across that more proximal lesion.
So why would that be? Any thoughts, Alison or Max?
I think there's a couple of potential contributors there. So you can see that there's a sharp angulation there partly, so that's potentially a bit of the issue, the tortuosity. The stents obviously do look quite underexpanded, and they're probably under some calcification as well. And it looks like, I'm not sure if there's a bit of an overlap of a stent there, perhaps. Bit hard to see from here, but I think there's multiple factors contributing to it. So maybe starting off with small balloons to create a tract and getting your guide extension seated a bit deeper, and you can go down the whole algorithm of gear won't go eventually with this.
And one thing to remember always in these cases, the first thing is check your wires actually didn't go under the stent strut, right? So always try to wire with a loop, because sometimes the wire goes under the struts, and that's why you cannot deliver.
No, absolutely. And I tried all those things that I learned from Dr. Balakis' books, but I couldn't get anything across. So I went with a laser. Used a 0.9 millimeter laser. Laser on contrast, as you all know, is off-label, but I used 70% contrast to get past that first lesion, and then 100% contrast to get past that second lesion, and for a total treatment time of about 3 minutes. After which I was able to get a balloon. I'm sorry, go ahead. Oh, sorry. After which I was able to get a balloon down and balloon angioplasted with a 2.5 by 20 millimeter balloon at high atmospheres. After which OCT was performed, and despite that balloon angioplasty, you can see the minimal MLA is 1.2 millimeters squared. So then I took a shorter, 2.5 by 12 standard non-compliant balloon at high atmospheres, and you can see that it's still a significant waste there. Using a OPN balloon, a 3.0 by 10 millimeter at 35 atmospheres, nicely expanded that lesion.
The conversation was earlier on that there's concern about deliverability, right? And here you had some issues earlier on. Did you have difficulty delivering the balloon to the lesion?
I had no difficulty at all. So after the laser and pre-dilating, I had no issues delivering this. So the more proximal and mid portions of the stent were then post-dilated with 3.5 and 4 millimeter NC balloons. Final OCT shows minimal stent area of 4.5. Significant improvement, and you can see, I think the angiograms speak for themselves. I think the results are pretty good. And after this, it's been about 6 months, and she's had no recurrence of her symptoms.
Did you downsize the size of the balloon? That's what people say, right? What was the size of the OPN that you used?
So I used a 3. And, because it was under 3 layers of stent, I thought the risk of perforation, that type of thing was very low, and that's why I sized 1:1. But normally I would go down by half a millimeter.
And actually, I would argue you undersized.
Okay.
I think that this vest, middle AD in a man, I mean, it's not going to be 2.5,
Oh, yeah, so
right?
she's a
It's a woman, whatever.
Yeah, so yeah,
But still, I mean, it's
I
not
see
going to
your
be a
point.
2.5 vessel, so.
No, I see your point. So that being said, I agree with you. Now, the things I was going through here, I even got contralateral access in the other groin, thinking like, God forbid, there's a perforation, I'm going to need to put an impeller right away, and this and that, So maybe I was a little bit, conservative in my approach with the OPN and pre-dilating.
Looking back on it now, as your experience has increased, would you go with a bigger balloon or higher pressure, or do you feel like this is a fully adequate result?
I think this is pretty good. You guys would love to hear your opinions. 76-year-old female. I mean, minimal luminal area is now 4.5, so it's greater than 4 in a LED vessel, mid LED. I mean, I think that's should not have symptoms with that.
I think you made a decent choice in terms of your balloon sizing. Again, imaging can be helpful, but I would tend to potentially downsize by at least 0.5 if I'm going to take it to super high pressures initially, and then you can always go back if you really want to with a larger one subsequently, but looks like it did the job for you for sure.
Any questions from the audience that come up, just raise your hand, we'll bring a microphone to you, okay? So just feel free. All right, and then you have another case?
I do. No, thank you. So here's another case. I mean, I think we've all been in these kind of situations. 82-year-old gentleman presenting with an anterior STEMI. Only thing we know about him is that he had a PCI in 2013. So there's his EKG. So I went via the right radial artery. I tried a bunch of catheters. I couldn't engage anything. So then I went through the groin, and even then I tried a couple of catheters, and I couldn't engage anything. And by sheer luck, I saw the old stents in the LAD, and I was able to put a wire down there.
So what would you guys do in this situation? So you cannot essentially reach the vessel. It looks like the aorta is a tortuous mess. I mean, what would you do?
So one thing, if you're dealing with tortuosity through the iliac and aortic system, you can consider putting in a long sheath to help reduce that somewhat and allow you to navigate your catheter a little bit more readily. Otherwise, I think, you're trying a lot of the right things there. He's got a guide extension and free wiring, and then you can always use gear to help pull yourself in further once you get access to the vessel.
Essentially what you do is airmail, right? You put a wire being far away from the vessel, and you have a wire there. You can sometimes actually put a stiff wire and exchange the guide for a different guide, like an EBU 4045 or something like that. But this, again, beautiful example of the guide extension on the right side and being able to reach it that way.
Sure, and you're absolutely right. I did have to exchange out for a 25 centimeter sheath, a little bit longer to get past the iliacs. Got a wire down, and then I couldn't deliver anything else but a 2.0 balloon. And at this point, patient's not doing well. He's now becoming more hypotensive. He's on one pressor, and then we're given boluses of phenylephrine to keep his pressures up. So at this point, and I can't get the wire any further down. And so at this point, I said, I have to put in support. So I went to put in an impella. So here's the access I got. Now there's a lot of tortuosity in the iliacs, but I thought,
what's the cardiac output here?
So there's a lot of tortuosity in the iliacs, but I thought, once that stiff wire goes in, I'll be able to put that 14 French impella sheath in. And I was wrong. I got the impella sheath in, but it would not make that curve. But then I thought, you know what? That's enough. I'll be able to deliver the impella. But I was wrong on that too. So I wasn't able to get the impella down on that, through the left. I was hesitant to go. It took some work to get into the left main, and I was hesitant to pull everything out and get access on the right. And then I just wanted to throw this up there. So interestingly, one of these glucose monitoring, continuous glucose monitoring companies, came to us, some of the doctors saying, do you want to try it out? I'm sure you've seen it. Patients have like a patch on there. They can check their glucose whenever they want. Since I don't go to a doctor, I figured, might as well try it out. Make sure I don't have diabetes. So what's interesting is that bigger spike is dinner time, but that 1600 spike there, that was during the PCI. So so we're worried, we're worried about radiation back problems and radiation issues, and now I got to start thinking about what these PCIs are doing to my glucose levels, So I realized then I would have to go via the right femoral artery, but I wanted to get something open before I did that, before I had to switch everything out, and using a microcatheter, I was able to deliver the wire a little further down, all the way down the LAD, and then using a 3.0 balloon, did a lot of pre-dilating, and that's the picture after pre-dilation with the 3.0 balloon. You can still see, it's kind of hard to appreciate here, but the left main, I think, is very short. The ostium of the LAD has a lot of disease, and the ostium of the circumflex also has a lot of disease. At this point, I went, for a 3.5, 15 millimeter OPN balloon. So now I've got, everything came out. I got the impella down. It was a lot easier to engage after pre-dilating with the 3.0. Use the 3.5 by 15 millimeter at 35 atmospheres to both the LAD and circumflex.
What was the wire you used here?
I don't recall. Probably a run-through or whisper.
Okay, so you heard this morning, right, from the talk from Dr. Katri, that you want to use special wires, right? You want to use either BMW or you want to use run through is okay. You don't want to use the Sion blue. That's the one you're going to, because then you're going to get stuck and you're going to lose the wire access coming back. And often it's good to put a body wire, but clearly this worked out great.
So after pre-dilating both the circumflex and the LAD, you have to remember also that he's not doing so well. I don't even have a creatinine back on him. Creatinine finally came back. It's like 1.9. So deployed a 4 by 28 millimeter stent from the left main into the LAD, and I just kind of left the circumflex alone. And I think it looks pretty good. So Perclosed the left. The impella stayed on the right. 2 days later, it was removed, and he went home like day 5. So in conclusion, the first case kind of gives us an example of the importance of imaging before any kind of intervention as to not get into a tough situation like that. Common reasons for ISR are stent under expansion due to calcium behind the stents and neoatherosclerosis for calcium. The OPN balloon offers a versatile solution for severely calcified and non-dilatable lesions, and they're safe and effective both in ISR as well as de novo disease. I appreciate you guys' time. Thank you for your attention.
Thank you. Next we have Allison Hall talking about pre-cracking the plaque technique.
Okay, good afternoon, everyone, and thank you very much for including me in this session. So pre-crack the plaques. So just initially exploring the concept, what do I mean by that? So let's suppose, for example, you have a very tight coronary lesion with an inner ring of calcium or severe calcific disease in that very tight lesion. It's expected to have a pretty small initial lumen as you first approach the lesion. This concept involves sizing the OPN to the lumen diameter, not to the EEL, and inflating to 35 to 40 atmospheres, maybe occasionally even more than that, to provide a potent initial force to the vessel wall, cracking those more immediate regions of the plaque, and then subsequently using larger NC balloons to further expand the cracks that have been generated and to get your lumen gain. This is ideally done under the use of imaging guidance, and then, of course, you proceed ultimately with placement of your stent. I've just drawn this schematic to demonstrate what I'm talking about. I don't know if I have a laser pointer. I do. So actually, I'll go up here. So basically, again, you have this inner lumen size, which is what you're roughly going to measure in terms of your size of your OPN. You have this inner ring of calcified plaque, then your larger burden of atherosclerotic plaque in the vessel, and then the dark line representing your EEL. So getting in with your smaller OPN to high pressure, providing some initial fractures to that ring, then expanding with larger NCs, expanding those cracks further, and ultimately getting a good stent result. That's the rough concept. So just a first case here. This is a 51-year-old lady who was admitted with unstable angina. She has a number of comorbidities as listed. And in fact, she had had an outpatient CT coronaries attempted to explore her symptoms, and she had too high a burden of calcium in her LAD to get adequate lumen assessment. So just keep that in mind. Sorry, I'm going to go back there. So this is, just going to go back again. This is her initial angiographic shot of her LAD, so you can see that there's two tight tandem lesions, especially that more distal lesion, probably 90% or greater narrowing in the mid-LAD, and the lesions do look even angiographically quite calcified. So initially I passed an OCT prior to the intervention. The imaging was not great given how tight the lesion was, but you can appreciate a very tight stenosis. This is at the distal lesion site with a ring of reasonable calcification, at least 0.5 or more thickness, and a decent arc of calcium around that lesion. So the proximal lesion on that initial IVUS was actually not well seen. You can see it there on the leftward panel. That's contaminated by blood swirl. I didn't get a good sense of it. And then the distal reference vessel you see there was at least a 3 millimeter diameter vessel. So I ended up taking a 2.0 OPN to the lesion initially and inflated it to 40 atmospheres. And you can see some small calcium fractures that have been generated in that inner ring of disease, as I was showing you earlier. And
maybe you can ask people, because that's a point that doesn't get emphasized very much. That's a beautiful image. How many of you image after you do OPN or other calcium modification to see the fractures? How many of you actually do this on a regular basis? So a minority of people, right? So this is something that you can do quite often, both with OCT and with IVUS. It doesn't cost you anything, yes, it's an extra run, but then you can know, you can see on the bottom right, there is essentially discontinuity, right? It was around calcium, now it's not. So there's all these cracks on the calcium. The more you do it, the more you're appreciative. When you see those cracks, then the chance of expanding are very, very high. So great thing to do, doesn't take too much time.
Mm-hmm. Okay, so, and that's just an image of the proximal lesion. I wasn't really targeting that lesion as much with this technique, but you can see even so at that larger site, there's still some initial cracks that have formed after the 2.0 OPN. So then I went in with my NC balloons with the goal of further expanding those cracks and getting some more lumen gain. And you can see that it looks like I'm achieving that goal in these images. I'm getting larger fractures and expansion of the lumen. And I sized that 3.0 roughly to the distal reference vessel, as was mentioned. This is the proximal lesion after the 3.0. So then I was satisfied with the amount of cracks I was seeing and felt I could go on to place my stents. So I placed a distal 3.038 stent and post-dilated that with 3.75 and 4.0 NC balloons. And you can see the final stenting result here with good lumen areas throughout in the range of anywhere from 6.3 up to as much as 9 to 10 millimeters squared, depending on which portion of the lesion I'm in. I'll show you some co-reg images shortly. And this was the proximal lesion where I placed a 3.5 stent and post-dilated with a 4.0 NC. So again, nice expansion at that site. And this is just to show you that I'm not making this up. So this is with actual co-registration. So you can see my co-registered marker right within that lesion and what the lesion looked like initially prior to any intervention versus the post images with co-registration throughout that disease segment. Okay. So, and this was the final angiographic result that you see there. That's with the OCT catheter still down there, so there's a little bit of blood swirl there. And that patient has done well clinically. She hasn't had her follow-up yet. It was a pretty recent case, but no new admissions or visits to hospital. This is just a quick example of another case here. A 73-year-old gentleman who had an NSTEMI multivessel disease and was a surgical turndown. I had actually already intervened on his LAD earlier in this case, but now I was turning my attention to this very calcified circumflex OM lesion, as you see there. And this is a case where I did a pre-crack technique without initial imaging, and the reason being I was not able to advance an imaging catheter down there because of this tortuosity in the proximal vessel and the severe calcified lesions as well. So what I did, I took initially a sapphire, a very deliverable 1 millimeter balloon, and did multiple inflations that allowed me to subsequently get a 2 millimeter balloon down there. Then I took a 2.5 OPN down. I inflated it to 35 atmospheres multiple times throughout the lesion, was subsequently able to get larger NCs down, and with use of a buried guide extension was able to deliver a drug-eluting stent with a reasonable final result. So again, I would encourage you to use imaging obviously for all of these cases, but even when you can't, if you downsize the balloon appropriately, you can proceed pretty safely with your intervention. This is my third and final case. So this is a 79-year-old gentleman, had multiple comorbidities, also came in with an NSTEMI with a myoview showing a major area of ischemia in his infralateral wall. And that was done prior to cath because he did have renal impairments. So they were seeing initially how high risk were his findings and whether to manage him medically. But with that myoview, he went on to have a cath. And he did have multivessel disease, but was turned down for surgery. And the consensus plan was to treat his RCA and then to see how he did essentially. So it actually looked like a CTO on the first angiogram that he had done, so I set up with a dual injection, but it's a pretty subtotal occlusion, but very short there, very calcified looking. So pre-PCI IVUS, you can see that there's a tight lesion there with, not a complete arc of calcium, but fibrocalcific disease and a small inner ring of calcium around the tight area of disease. So I took a 1.5 OPN down to that tight lesion site and inflated to 35 atmospheres, and you can see some small initial cracks in the inner ring of calcium. And then I was able to go down with larger NC balloons, in this case initially a 3.0 NC, and this is what the vessel is looking like at this point. I then went down with a 4.0 NC throughout. And you can see again that concept of expanding cracks as we go up now with these larger balloons, which are marked with the yellow arrows. And I took a deep-seated guide extension down and started to deploy my stents through the mid-vessel. So I deployed 2 drug-coated stents and dilated with large NCs. And then I had the distal disease to deal with. So now I was at the point where I was going to do a pre-crack technique on the 2 distal lesions, in this instance without imaging guidance, just given the small vessel and distal nature of the lesions. So I took a 1.5 OPN down to the posterolateral branch first and inflated it to 35 atmospheres. I further dilated with 2.5 NCs and placed a 2.5 stent and post-dilated with a 2.75 NC. And then I went down to the PDA and did the same thing. I took a 1.5 OPN up to 35 atmospheres, post-dilated with a 2.5 NC, and placed my 2.5 stent, dilated it with a 3.0 NC. And this is the final angiographic result for the patient. And I do have a complete IVUS there that does show good stent expansion and opposition throughout the vessel. And that patient has done well. So ultimately, in terms of the pre-crack technique, for advantages of it, well, small balloons will sometimes go where larger balloon-based devices may not travel, so that can be a potential advantage, especially after you potentially dilate initially with low-profile balloons like Takiro or Sapphire. You don't need any adjunct equipment here. It's obviously a balloon-based technology, so it's simple and a bit more cost-effective potentially. Anyone can do it without additional training, provided that you have understanding of how to use the device effectively. And going with that very small OPN initially may further improve your safety margin with the device. Of course, there's an unlimited number of inflations that you can do, and you can inflate over a long lesion, so that's handy as long as you use a compatible wire that's not going to stick to it. Some limitations or potentially evolving questions. So it has to be a balloon crossable lesion, of course, so otherwise you'll have to do rhoda or something else. The efficacy of this technique in nodular very eccentric calcium, I would say, is probably more limited. So in that instance, I might go towards something else. We don't really have a direct comparison as to how effective this would be versus just starting with a small NC at high pressure. But given the nature of the OPN and the large initial force that it's going to provide, I would expect it to be superior, also based on my experience with how typical NCs perform in these calcified lesions. And the other thing is, how small should that initial OPN sizing really be? So you have to look at the safety margin versus your efficacy. There may be an instance where you start with that 1.5 or 2.0 and it doesn't adequately modify for you, and then you have to upsize, which would just come at the cost of another OPN essentially. So that's my talk. Thank you very much.
Thank you, Allison. Just to highlight the cost effectiveness, the OPN balloon is listed as $1,200, whereas your shockwave is $4,500 and your rota is about $3,800. Question for you on the case that you showed where you had to go distally. Were you able to use the same balloon multiple times, or did you pull out a new one?
I did actually for the OPN. I did use the same 1.5, but it's a good point. Sometimes when you've already inflated a balloon, whether it's an NC or an OPN, it can be more difficult to deliver it that second time. So you would just have to take a new device if that's the case.
Sanjit, welcome. I know that you had some trouble, so thanks for making it on time. This reminds me of the 1.5 rota. You don't need two rotas, 1.5 works. Have you used this technique? Is it a Canadian or is it just a Newfoundland technique at this point?
I have not used this technique, but I'm really intrigued. The smallest device we have, OPN, on our shelf is 2.5. And so for a number of these lesions, if they don't dilate with an NC, we either use an OPN or shockwave in that case. But I'm intrigued by this technique, and maybe it'll spur some ideas.
Yeah, thanks again. Thanks so much, Alison. Oh, I'm sorry, there's a question over there. Do you mind just giving the microphone?
Mm-hmm.
But it's usually if we're using bigger balloons, high pressure for ISR. And so we're worried about like the balloon seizing on the wire potentially. And this, is that less of a concern when you're using these smaller balloons? Maybe you're not anticipating going up at 45, 50 anyways?
It's actually still a big concern. So the reason I use one wire is because I have a fair bit of experience with these balloons, and I find that I can get away with it if I choose the right wire. If you're using a Cyan blue, it will absolutely stick to it. I do think it's less, though, yes, than when you're using the larger size OPN, but it will still happen with those small balloons if you're going up to 40 atmospheres, especially repeatedly, if you use the wrong wire. So I tend to use, when I'm using OPN specifically, I tend to use a lot of run-through extra floppy, or you can do exactly as you said and just put a buddy wire down. So I would still be cautious of that. So either using a wire that you've had good experience as to not sticking to the device, or just throw a buddy wire down. Yeah, thanks.
Wonderful. Thank you. Thanks again. Thanks so much, Alison. The next talk will go back to the original schedule to Dr. Sandy Jolly. Will talk to us about when plaque modification fails, which, as you've seen, happens quite often. But you see some patterns emerge.
Can we change the slides, please?
I think it's listed as number 4.
This is what the slides are coming up. That's about your experience. How long you've been using the balloon? How has your experience been overall?
So it's interesting. When I first used shockwave in 2019, full disclosure, I bought a bunch of shockwave stock, and I should have held on to it until it was acquired by J&J. And we had some fellows from Switzerland, and Switzerland is the home of OPN NC. And they say, we don't use shockwave, we just use the OPN NC. I said, okay, we need to get it in and see how this is. And I'll be honest, I was blown away about how effective it was in calcified lesions. Okay, keep on talking. Okay, so I'm gonna show a note. I'll first start off with my disclosures. I am a speaker for CIS as well as Shockwave, both companies. And I think I'll just start off is that we are running the largest randomized trial of calcium management in terms of Shockwave versus OPN NC. So it's called the Victory Trial, and we're excited to be able to show that. Okay, what is the evidence? Well, there are several registries. The first one is the OPN registry. In fact, Natalia Pinelli at our place ran the OST core lab. It took 50 patients with calcified lesions, similar to the shockwave studies, and they downsized by 0.5 millimeter, and 80% of patients had greater than 80% stent expansion. So it worked a large amount of time. There's even a larger European study, more than 300 patients. They looked at the classic scenario. You take an NC, there's a waste, it fails to dilate. They downsized by 0.5 millimeter. They imaged everybody. And what was interesting is about 60% dilated between 30 and 40 atmospheres. And then they went off-label, and they went above 40 atmospheres. And actually, the vast majority of those dilated when you go above. So I have taken the OPN off-label up to 45 atmospheres. And there was a 1% perforation rate and very high chance of success. So if all else fails, you can crank up that OPN with care. There's a randomized trial called the ISAR Calc trial looking at the super high pressure balloon versus a scoring balloon. and showed initially a better reduction in diameter stenosis, but the final stent expansion was fairly similar. So I'm going to go to a case. This is a heavily calcified RCA, and the patient had an anterior STEMI previously, and the question is, what would you do? Many people would rotor this up front, but our approach was to wire this and image. And what we found was nodule after nodule, as you can see here. We actually elected to try we tried an NC balloon. It would not expand. We tried a 3.0 IVL, both distally and proximal. And you can see the IVL is not expanding despite all 120 pulses. So this is really a failure of IVL therapy. And the question is, what do you do? And we experienced this. Particularly in nodules, this will happen in about a fifth of cases. We then took an undersized OPN, 2.5 OPN. It actually looked much better. We then imaged, and you can see that nodule is certainly pushed away with the combination of IVL and OPN. So this is the idea that maybe they can work together, that you'll have some IVL case failures and you need to use OPN. And this is the final result. The area was quite good. There's still some underexpansion in that segment, but we were fairly satisfied. And this is actually the final area, which was quite good. Okay, next case, a 71-year-old, non-STEMI, prior cabbage. Full disclosure, this case was not done by myself, so there were two procedures. This is the initial procedure. You can see there's a stent in the ostium of the circumflex, and there's restenosis. The operator did not perform imaging. They took a 3.5 NC that did not expand clearly. They took a 3.5 IVL, which did not fully expand. And then they went and used a drug-eluting balloon. In Canada, we have the Pantera Lux. A 3.520. There was some better expansion, and this is the final result. And the operator said, this is good enough. We're done for today. And guess what happened? 5 months later, the patient was readmitted with unstable angina and had recurrent restenosis. Not very surprising. What was the mechanism? Likely underexpansion. And this time, we imaged. My colleague imaged. There was calcioid nodular neointima, as you can see here, and very, very tight stenosis. And what they did was they actually used a 3.5 IVL after an NC. The IVL did not expand very well, as you can see. There's still quite a waste. They used a 4.023 Zients, and that was underexpanded. And then they imaged. And I'll show you what the OCT is. And what you can see is the area is still about 4 millimeters on either side. It's 9 to 10. And so there was clear underexpansion. You've got a lumen of 2 millimeters in a 4.0 stent. And the person said to me, what should I do? I said, well, take an OPN NC. And so that's exactly what they did. They used a 3.5 OPN, so undersized it. And the area went from 4 millimeters squared to almost 9. And so really, despite NCs, IVL, the OPN NC was essential in this case, and I think really every cath lab should have it on their shelf. Okay, let's move to the next case. So this is an RCA lesion. Actually, I forgot to insert the first image here, but heavily calcified, needed rota, nothing crossed. And what you can see is this is the OCT run, is heavily calcified. Orange shows you calcium on ultrasound 4, and it's really circumferential calcium with some nodules as well. So the question is what to do next. So this patient had IVL therapy, 3.0 IVL. Actually, this is a scenario where you have nodules and the balloons rupture. So actually 2 different balloons ruptured, and more than 180 pulses were delivered. And despite this, on the next image, you'll see that an NC balloon was not expanding. 3.5 at 26 atmospheres, and it ruptured again. So the question was, what do you do? This patient has already had rota. Do you come back with a bigger burr? And so the choice of the operator here was to take a 3.5 OPN NC up to 40 atmospheres, so higher than and it held pressure. And this is a double layer balloon, so often it'll be less likely to rupture than a standard NC or an IVL balloon. So I have used this successfully in this scenario. And in fact, what you see is they put 2 drug-eluting stents. They post-dilated up to actually with a 6.0, and you can see the OCT run. The areas are still quite acceptable. There is, some underexpansion up to around 60%, but those areas are quite good, and the operator was fairly satisfied. So the OPN NC is an essential tool in the cath lab, particularly when other calcium modification fails, whether it's ROTA or IVL, and it's particularly valuable for stent under expansion. And I believe it probably works better than any other device on the market when you have an under-deployed stent. And we all have that situation where you have stent regret. The key to stent regret, or the one thing that can bail you out, is the OPN NC. Finally, this is the design of the Victory trial. The PI is Florem Cecily from Switzerland, as well as Matthias Passard, one of our former fellows. Our institute at PHRI McMaster is the Angiographic and OCT Core Lab, and we've actually randomized 260 out of the 280 patients. I am hopeful that we may be able to present this at TCT as a late-breaking clinical trial. And the primary outcome is OCT-based stent expansion, so every patient is imaged in this trial, and it's a non-inferiority trial comparing OPN versus IVL. Thank you.
So, Sanjit, you said you don't do pre-cracking, but the first case was a pre-cracking. So you've been doing it all along. But jokes apart, this is phenomenal, a phenomenal expand. So maybe Max, you have a tremendous experience with the balloon, and do you use it both de novo, in-stent, and do you do any difference in how you use it in the two things? Do you feel safer in the in-stent?
Yes, thank you for the question. I think the presentation can give you a little bit idea. Yes, it's in both situations needed. The resistant lesions are not only the evil calcified or nodular lesion. The stent is an issue. The stent is an issue. The stent is the disease, most of the cases. In the index procedure, not well done, without imaging, without proper lesion preparation, the stent still remain an issue. And we have the same experience like you. IVL in-stent doesn't work like the opens in the same fashion. So I think, yeah, we use in both situations, and not only in this situation, uncrossable lesion, like you showed before, just the rotablator cross, which is the next step? This is the question. After the rotablator cross, lesion is still there, which is the next step? So I think this is a lot of question about the evil calcified lesion we need to answer in the future.
Yeah. We'll have some data from the Victory trial because rotablation is allowed. And so you will have patients where you had uncrossable lesions, had ROTA, and then were randomized to IVL versus OPN NC, which will be very interesting as a subset.
Very interesting study. We are performing in Munich the concurrent study, then ISAR-Calc 2.
Okay, yes.
Maybe we could pull the data
yes,
next year.
Put the data together, absolutely.
Question about the perforation, because I think that's on the mind of many operators. I mean, is it safer for the OPN balloon because of the double layer design, the lack of puncture and perforation of the balloon to avoid coronary perforation, or is it still a risk because of potentially oversizing and pushing out a nodule out the vessel?
So what I would say is that in concentric calcium, as long as you undersize, it's quite safe, and I think Allison will attest to this. I think where you can run into problems is when you've got eccentric calcium and it only expands in one direction and you oversize that balloon without imaging, that's when you run into problems. And so I think it has to be used carefully, and we always think that, you know, this doesn't require any training. What I would say is that we image these cases and we specifically undersize. Occasionally we'll go one-to-one, but I think for the most part we undersize, and you get excellent areas with this technology.
Specific to the calcified nodule, I mean, one might think that that could be at risk of perforating because you're dilating in one direction. What do you think? I mean, is this I mean, you described several cases here that the calcified nodule didn't scare you from using the OPN balloon. Is this a preferred device then?
I think the randomized trials will tell us, because we've got a subset, nodular calcium is included in the trial. So I think the jury's still out. We have registries suggesting it's fairly safe. But if you believe Shockwave, you know, you should use Shockwave in every nodule. The question is, we don't have randomized data to support that. So that's where I think, I mean, Eclipse, if you had believed Eclipse before that, everybody should get orbital who has a nodule. And clearly that's probably not the case. It's only a subset that need atherectomy.
One question, the perforation question comes up all the time. Do you do, apart from undersizing, do you do anything different? Have you had any perforations? And if you have one, how do you treat it?
So I think we've all had perforations, and if you haven't had a perforation, you're probably not doing tough enough cases, as someone perhaps has told me. And I have had an OPN NC perforation, and they can be bad. I think the important thing is you need to be prepared, And I think the most important thing is as soon as every time I inflate an OPN NC or an oversized NC, I will take a puff, a little injection, and as soon as I see the perforation, I inflate. And then once you've inflated, you stop the bleeding. You can do your ping pong guide. You can use, we've had Ringer balloon in Canada for a number of years, fantastic device in terms of perfusion and stopping the bleeding, ping pong guide, and covered stent. I think one of the challenges with covered stents in nodular disease is you can have trouble expanding that covered stent, and it can be challenging to create hemostasis. But I think there's certainly a perforation rate, but we know in calcified disease, the perforations there's a higher rate. A 1% perforation rate in calcified disease is probably pretty standard. Whether you look at rota, orbital may be a little higher. We don't know where OPN NC stacks up compared to those.
Great, thank you very much. We'll wrap it up with Dr. Max Fusaro with Many Roads Lead to Rome, 10 years of clinical OPN NC experience. Although this device is relatively new here, it's obviously had extensive experience in Europe and Canada.
And Dr. Fusaro is Italian, hence the Rome.
No German. Thank you, Manos. Thank you for the invitation. So Thomas asked me to bring the large experience what we got in German Center in Munich. That's not the presentation. Yes. And the reason is why they accepted that maybe not focus only of the evil calcified lesion is quite important, but maybe a little more bright spectrum of understanding, which is a resistance lesion. The resistant lesion is not an evil calcified lesion. Imagine define it with IVOS or OCT, or even in coronary CT. But we got a problem nowadays, a situation, many different situations with the stent. We have a lot of stent underdeployed, underexpanded, with stent thrombosis, recalcitrant in stent restenosis. The stent is an issue nowadays, and undilatable lesion, even after rotablation and IVL, a resistant lesion or not crossable lesion. So in the modern approach, what we do in Germany, at least we perform much more CT scan before we put a complex PCI on the table, so we got much more information about the distribution of the calcium. I don't know which is in US. This is a case that's in every pamphlet of the OPNC is present, was performed in German Center at that time, and this is a recruited case for the prepare calc study, randomized tried rotablation against cutting balloon. At that time, we randomized the patient in the cutting balloon, and even this is the NS alpha in the middle. The cutting balloon failed to reopen the artery. There's a clear nodular calcification. So switch to the rotablation was per protocol was present at that time. And the high pressure balloon dilated the artery, and we put a stent. We was able to put a stent. This is the final angiographic result. Per protocol, we got the possibility to perform the OCT, and this is the problem, what you see on the OCT. Looks good angiographically, you perform cutting balloon, you perform rotablator, you think I'm okay, you are not. Not at all. This is in the pre-use of OPN NC. I remember the day in which Willits-Wallen presented the dual-layer balloon to us more than 10 years ago, German Center, and we were skeptical, which is the use. We use rotablator, we use cutting balloon, but soon we understood we got a lot of problem, for example, in stent. We started with stent. There's a clear stent failure because the stent with acute coronary syndrome, and this is what you have. In most of the cases, the stent fell because not well expanded. And this is what you can see, that dog bone effect. And this is the use, one of the first uses of OPNC, 45 atmosphere, off-label. We didn't know at that time. We still perform with 45 atmosphere, but not in every case. There's another case of instant failure. There's a myocardial infarction. Even in such situation, you don't need imaging. You see with the magnification. We got a Philips. I think there's a stent bursting field is possible too. And you said that the stent not completely expanded, nodular calcification behind the stent struts. And that's what the operator did at that time. NC balloon, 24 atmosphere, and this is the result. We put a stent inside because not for there's a situation where you have to stabilize the patient, and I want to spend 10 seconds to understand how we how we perform in Germany the dilatation of the balloon. So don't start to go to 40 atmosphere in your first dilatation. That's not completely intelligent to do that, and it uses a little your brain. So go to 25, 30 atmosphere first and keep the pressure there, 10, 50 seconds. Don't be afraid. Deflate and check. And the next step is 35 atmosphere. Keep the pressure there. Deflate, check. So you check in every time, every 50 millimeter, 5 millimeter atmosphere more, you check continuously the situation until 40, 45 atmosphere. This is the safety way in which we learn to use the OPNC. But I'm open for other technique in which we can discuss later. This is the final results, and this is the reason why I show the case that 2 years later, still in good shape. There's a case of a couple of years ago about the body wire technique. Someone asked me about the body wire technique. Yes, there's an issue with Xeon blue. It's not suggested to use OPNC on a Xeon blue wire. Personally, I use Pro Water, very old wire. Maybe our generation remember this wire, Pro Water from Azai. It is a very old wire. But why I show you that? Because the cutting wire technique was most of the case used. You can appreciate in this case that the wire positioned in the right position can push the stem struts easily against the wall and cut the plug behind the stem struts easily, so you don't need to go up to 40 atmosphere, 45. Most of the cases with 2 dilatation, 30 atmosphere with the body wire technique around, you can have a good angiographic result, and this is the pre and post cutting wire technique. So I repeat, you must use most of the case not to 40 atmosphere, but with body wire technique less. 30 atmosphere does the job because we are helped from the wire. So first, cutting balloon, rotablation, instant problem. This is what we learned. Later on, this is a typical case in which you need the rotablation, because how you want to treat that? First of all, prepare the lesion, crucial point, and you prepare the lesion at least with rotablator. But what's the next step after the rotablator? So we decide to reopen, to dilate the entire artery with OPNC balloon. But even that, with high pressure balloon, 24 atmosphere, doesn't work. And this is the OPNC, 40 atmosphere. Not in every case you have this effect as the OPNC balloon dilate, bam, there's a pop effect the artery. Sometimes you have to convince the artery to become bigger and bigger. So you need much more dilatation. If you remember the first case, cutting and rotablation, and the picture of the intravascular picture after the first case, you can appreciate the big difference right now with OPNC, the rota and OPNC, compared with the rota and cutting balloon, the first case. So this is another case in combination IVL and rotablator, easily calcified lesion and many stent layer there. So we decided to use everything what we got. In this case, IVL and rotablator. This is the shockwave balloon, quite open the artery, and this is an OPNC balloon that completed the expansion of the artery. And after 2 stents, you can appreciate how much calcium is around. There's a coronary artery. Extremely case. We got a couple of minutes again. What about lesion that's not crossable with nothing what you got? Balloon, microcatheter. This is a typical case in which nothing cross. CTO guide know this. And especially in such kind of situation, I used to do that. I remove the CTO wire and I renegotiate the lumen normally with a Rota Pro floppy wire to prepare for the rotablation. We perform the rotablation, and do you think everything is okay? Wrong. This is only lesion preparation. As you can appreciate to the right side, there's a body wire technique. There's a normal high pressure balloon. With the normal high pressure balloon and body wire technique, was unable to expand the artery. So still present with a terrible dog bone effect. And this is the reason why. It's nodular calcification and the presence of the stent struts. So you need power to reopen this situation. This is OPNC dilated many times. I remember the case until 45 atmosphere. And this is the final angiographic result. So another situation with uncrossable lesion and undilatable lesion. Similar cases, CTO, rotablation. Why I show that? Because not every case you can see there's a pop effect of an OPNC. Sometimes you have to have patient and reopen and dilate, like I explained before. 5 millimeter deflate, check, 5 millimeter, and we went at that time 50 atmosphere. Sometimes nowadays maybe I want to make difference in this such patient like that, but this is the reason why I want to just say. I'm sorry, just this one. One thing more. This is a combined analysis published in European Intervention, in Euro Intervention 2020, a couple of years ago. But just to answer one question, prepared calc and ISAR calc trial, rotablation and against cutting balloon, and ISAR calc 1 trial was cutting balloon against OPNC. We combine at patient level the data, and this is what the summarized in this picture, in which you can see that the rotablator give you the maximal strategic success. You cross the lesion, you can prepare the lesion with rotablator. But the maximal stent eccentricity, there's a parameter of how good you expand your coronary artery, is not done with cutting balloon, but with the OPNC. So personally, to treat such kind of lesion with rotablator, I use OPNC balloon because the data and the pooled analysis support that. So I'm really curious to know the result of the victory trial in TCT this year. Just can't wait to use that. Thank you very much.
Thank you very much. I like that your approach of using all the above. Catherine has a question.
Yeah. No, it's not an angiogram. It's just a check with a little bit 3 milliliter contrast meter if you can see the explosion of the artery or not. Check for perforation. Because all the time I can hear just that it's the perforation. The perforation is really rare, but just to feel the beginners a little bit more confident with going to high pressure, please don't go to high pressure to 0 to 200. Try to modulate your high pressure and check every time and keep the pressure there. Don't be afraid. The balloon have an incredible resilience. Just try that.
So I'm hearing undersized balloon, slow inflation, check every 5 atmospheres if you're going above certain pressure. I see a lot of people's eyes bugging out. Us Americans, we're very fearful of malpractice. Well, how do you reassure us that going up to 45, even 50, will be safe? And what do you tell to us Americans? This is a compliance curve of OPNC. Just to understand how we say underexpand. An OPNC balloon, normally, until 35 atmosphere, maintain the diameter. Okay, up to 35 atmosphere, the gain is 0.5. This is the concept behind undersides. This is the concept behind the undersides. Understand that this concept means that you can modulate the pressure in which you deliver the pressure to your balloon. So safe is until 35 atmosphere, because you just gain 0.5 millimeter. And if you schedule, if you perform imaging, you know the diameter of your artery. Undersides the pressure, and can be sure that until to 35 atmosphere, nothing happens. That's what the schedule. Only thing what we got with perforation, if some nodules, the nodules perforate the arteries sometimes, but there's only, in clinical experience for me, is a rarity. I don't know which is your experience, but the nodular perforation.
Yeah, I mean, you see them occasionally, but particularly in eccentric nodular calcium.
Yeah, eccentric, yeah.
And particularly with oversized balloons. And sometimes you get too carried away going 1-to-1 with a D-shaped stent, and that's where you can run into the problems. where your area is quite good and you should probably walk away and you just want a perfect round stent.
Perfect. So great talk. Thank you so much. I think we have like a couple of minutes, 30-second take-home messages from each of us.
You know, so I think it's been I think the OPN balloon's been a great adjunct for me, and you know, so highlighted by the second case. You know, I should have mentioned it during the second case in the STEMI. I think there's something to be said. You know, doing rotational atherectomy, orbital atherectomy, in that STEMI case that I showed, there's a certain amount of fatigue that goes into these cases too. Where you know, after a while, it's a tough case. You're trying to get the impella on the left side, can't get it in. Where I find that the OPN balloon, you know, is safer, has less steps, and you get the same outcome as doing either rotational or orbital atherectomy. And that's kind of my take home. It's been a game changer for me in that regard.
My take home point is every lab in the U.S. should have OPN NC on the shelf, given the fact that you may not be able to expand your stent. Number two, I think you should image routinely in these cases so you can size appropriately and use it safely.
Perfect.
I don't know if that's worked. I completely agree with you. Every catalog with complex PCI should have this one, and I think the combination, not only working alone is the OPNC balloon work alone very well, but the combination is maybe the future what we will see in the lesion preparation and expansion.
So I would just echo the comment that really in treating calcific disease, multiple tools are necessary in the armamentarium, but I find truly that OPN is a useful tool, and I would recommend that you have it as an option. I think the key is to understand it, and this chart here is actually really, really helpful. So you want to undersize appropriately and go to higher pressure rather than choosing necessarily a one-to-one or, heaven forbid, an oversized OPN and taking it to higher pressure. That's when you'll run into trouble. But if you gain experience with it and use it safely, it can be a wonderful tool.
All right. Well, three take home for me. Undersized by 0.5. Body wire. Use a BMW. Use a whatever, Grand Slam, whichever wire, but don't use Sion Blue. Number three, don't be afraid of it. Yes, perforation can happen in calcium at any time. Be ready to handle it. But this is not different. It's very low risk of perforation. Everyone worries about it. You should know how to do perforations because it can happen with anything, but this is not going to cause more perforations than the other devices. Thank you so much. Enjoy the rest of the meeting. There's a wellness going on. It's about half an hour. If you're feeling stressed and burned out, this is the place to go. Thank you so much.